Mike, I'll try, of course, then if I succeed or not, you will tell. And is two topics really, PK and inhibitors. Now, the bad news for you is that, as Mike told you before, this talk was supposed to be 10 minutes longer, so I will delay a bit your lunch. But the good news is that I had conceived this talk for the afternoon. And when I do so, usually I keep them lighter. So hopefully it will give you a bit of rest between the lot of very high quality evidence you saw up till now, and I'm sure that Kathy will not be lighter in providing us with the very good data that are coming up of gene therapy. So let's hope that it goes that way. My disclosures, and on the PK part, I'm the co-PI with Cedric Hermans on the WOPS project. Now, predicting inhibitor risk or predicting factor levels are both predictions, so they go through modeling. I'll start on PK because it's what I like doing most these days, and also if I don't do it now, when gene therapy will take on, there will not be any more need for PK, so better to do it now. Inhibitors, they will continue maybe, but PK, no. Is it possible or not to make a sensible and useful use of PK in the daily care of hemophilia? This is the question, and I'd like to have you active on your phones, if you can, to see where we start and where we end. Now, I understand many of you are trainees. You may not care directly for hemophilia patients, but hopefully, or not, I don't know, you have rotated in hemophilia clinics, or you have had some exposure to hemophilia treatment. So if you don't answer for yourself, answer for the one you learned about hemophilia from. This is the first question. Can we have it there? Yes. So do you use individual PK profiling for tailoring prophylaxis in hemophilia? Yes, in most patients. Yes, in some patients, and no. And the answer is yes, in some patients, as the majority, as you see on your screen, hopefully. Now, I have another question. Do you use WOPS for individual PK profiling of your patient? Of course, I speak of my own research enterprise, but can be any population PK approach. Do you use a population PK approach? Yes. Not yet, but maybe I will someday, or no. And the majority says either no or not yet. Changing averages. Yes, not yet, but maybe I will. Which makes sense in particularly in UK, where we'll tell you later how it's going with the accessibility to WOPS. Now, my final disclosure as starting point, I told you I kept this slide. I didn't put a lot of references in my slide to save space and make them easier to follow. But if you are among those that like to see where the evidence comes from, please refer to this paper I prepared recently for the ASH educational publication. I gave an educational on this topic at ASH this year, and there's plenty of citation and where what I'm going to discuss stems from, together with some clinical cases about how to use PK to individualize treatment. Now, going back to the introduction we had yesterday on the treatment of hemophilia, Lou reminded us about the mainstay of treatment being the comprehensive care and prophylaxis. Now, prophylaxis has been around for long, since the 60s, and the basic concept is, since mild and moderate hemophilia, they do not bleed, we increase their factor level constantly over time, and they will stop bleeding. Now, that's fine, and that will be what gene therapy will accomplish with a, hopefully, single shot and getting to much higher level than we can nowadays. But as we are today, with current available treatment, we are not in agreement about how much to give, how often, what are the trough to reach, and so on. And we all say that in treatment needs to be tailored to the individual. Now, there are in the literature and in the community two different opinions. Those that say you just need a clinical approach. You need to follow patients, see how much he bled, how much he has joint damage, and then you'll adapt treatment to clinical characteristics. And others that say, well, you'd better measure values and you try to guess how much factor is needed for each patient. What is my viewpoint, and I will try to convince you that there is really no double option, is that both are relevant. Tailoring can only happen if you use the clinical information and the PK information. I mean, it seems very obvious to me. You can say that is the clinical history, is the joint, is the level of activity the patient gets, but still what prevents bleeds is the level of factor. So unless you are really empirical and you shoot in the dark with doses, even if you take a clinical perspective, you need PK. And I'm the first one to say that PK alone doesn't suffice because it's not enough, because PK let you get a trough you want, but which trough is needed for each patient, you have to identify clinically. My second point is that we are using PK anyways in hemophilia. First of all, until recently, the only requirement for approval of factor concentrate was showing bioequivalence to plasma-derived factor VIII. There was no need for clinical trials showing efficacy and safety. You had to just show that after the infusion of any preparation, you were getting measurable level comparable to what you would have obtained by infusing plasma-derived factor VIII in the same patient. Very simple crossover trial, 12 to 15 patient, infusion of a standard dose, and showing bioequivalence. We will likely go back to measure factor level. When we can get significantly high factor level, we will not likely need any other proof. But in the history of hemophilia, after many factors were on the market, then the shift of the regulatory apparatus went on, let's show you can get the same level of protection from bleeds instead that a given factor level. So pharmacokinetics worked with hemophilia since the beginning of treatment of hemophilia, and we use it in clinical practice every day. When we say that we do prophylaxis and we choose a dose between 15 and 40 units per kg of factor VIII 2-3 times per week, we target 1%. We usually measure a trough here and there. That's a very basic way of using PK. When we do surgical perioperative management and we check a peak to be sure that he's in the 80s and our patient will not bleed, and maybe we check in the afternoon that same day where the level is and we decide how much to reinfuse, we use PK. It's a PK way of reasoning. Very rough, but still PK. And when we judge about ITI, ITI is when you give high dose factor VIII daily to patients with inhibitors to try to eradicate the inhibitors. We measure the disappearance of the inhibitor first, and then normalization of recovery, and then normalization of half-life. All of this is PK. Now, what we use in PK in hemophilia is some of what you can measure after a time, concentration over time disposition. You shot the drug, you get to a peak, and then if you measure over time, you see a decrease. And we define a peak or recovery, we define a trough. Trough is the level you reach before the following infusion, is the pre-dose level considering the following infusion. We can measure a terminal half-life, and we can measure an AUC. All of these we measure. Then we can calculate clearance, volume, K, average half-life, and so on. Now, there's a lot of discussion, again, your phone, about what is the most important PK parameter when comparing two or more factor concentrate. When I decide using a short-acting or long-acting, which one of these is the most important? Do we have this question? Yes? Your phone were all sleeping? All of the above. Okay, every one of those voting at least, maybe they are two, I don't know, but 75% of those voting says that all of the above are important. I don't really care which one is important. What I care is you reflecting on the question. Here is what's the most important when comparing 2 or more factor concentrates. Now switch to this question. Which of the same is the most important when tailoring treatment of an individual patient? You are now thinking of one patient, not a population of patients. You are not picking for your clinic a long-acting A against long-acting B. You are picking a drug for one specific patient. Which one of these is most important? There is more uncertainty here. For sure not the one above. You all realize you can't use all of these in clinic. You are good physicians. Terminal half-life seems to be the winner, followed by clearance, and someone wants to use more than one. Okay, now I will try to convince you that none of those is really critical. There is something else you really need. The ISTH recently has released a guideline about estimating and interpreting the PK profiles of individual patients with some very practical guidance about how to do an individual PK profile intended to be used to guide treatment. And before commenting on what those guidelines say, I want you to stay awake answering another question. Which of the following is the most important contribution of population PK modeling to the care of hemophilia? This guidance is about using individual profiling using population PK. Why we need population PK modeling? What's the main effect of using population PK? Introducing random error, increasing the feasibility of PK profiling, all of the above, none of the above. Increasing the feasibility. At the price of introducing some error. Modeling does always introduce some error. But the goal is to increase the feasibility. Now, the historical guidelines from ISTH were meant to support comparison of different concentrates. And so they proposed a 10 or 11 blood sample schema over 72 hours after a standard infusion dose, using 12-15 patients in a crossover design. This is an approach that is drug-centered. It requires a single, very standardized injection. It requires a lot of blood drawing, and it requires a washout. The washout in clinical practice is bloody. Patients, they bleed during washout. If you do an efficient washout, you wait for the factor to be completely disappeared from circulation, there is a high risk for the patient to bleed in that period. The new guidelines, focusing on individual PK estimation, propose to get 2 or 3 samples for each patient and to use a population approach to get the profile. So in this case, it's patient-centered. It happens over the normal infusion regimen. It doesn't require a washout. It doesn't require a fixed dose. It only requires to do sampling on the current regimen. And the sampling is much more limited. If you want to do the best you can, you do 4, 24, and 48 hours for factor 8. There are recommended time for factor 9, for extended half-life factor 8, extended half-life factor 9, and so on. But the samples are many less and can be taken after different infusion. Particularly in pediatrics, you can draw the 4-hour, the 24, and the 48 after 3 different infusions of the standard prophylactic regimen, and then you lump that information to get a single profile. So from the concentrate to the patient, from many to few, and avoiding a research kind of setting, doing it in clinical practice. Now, you may say, well, okay, but why now? Why we didn't think of these 20 years ago? I don't know, I was not there, but it was done in other fields for many, many years. And of course, you accept a reduction in the precision. I'm not here to say you can get with 3 what you could with 11, but Sven Bjorkman, 10 years ago, showed that with 3 samples for factor 8, you get 85% of the information you would get out of 11 data samples. 85% to me If I think of my practice, there are very few decisions I make where I have more than 85 precision about what I know behind my decision. So I'm happy with that. Anyways, let's focus on 3 more concepts that are hopefully helping you understanding why it's worth taking the effort of drawing those 3 samples. Modeling the inter-individual variability. We cannot really use average knowledge of a concentrate. Just knowing what the average behavior of a concentrate is in some population doesn't help us treating our patient best. And finally, we really don't need, if you take a pop-PK approach, we don't need to know almost anything about PK, which is good, I think. Now, in a graphical form, we need to know a bit more about variability. We need to focus on why choosing the longer half-life concentrate as demonstrated in a study population is not the best we can do for our own population. And finally, what we really need is a profile over time. For each patient, we need to know how his concentration goes down over time for him, and we need to have something interactive that let us target any trough we want and decide if a kid can play hockey on a Tuesday afternoon when infused on the Monday, because we know which concentration he will likely be at that time. If you have the time over concentration curve, you don't really need to know the clearance, the half-life, the volume, or anything else. What you can communicate to patient and model in your mind is where he will be at a critical time. Now, inter-individual variability. The variability in the response to a drug can be divided in some component. So there is a inter-individual, intra-individual, and residual variability. Let's leave alone the residual variability. That's what makes the 15% uncertainty. Let's focus now on the inter-individual, intra-individual. So in this plot, I have an hypothetical drug and I have a therapeutic window, a minimum and maximum concentration. And here I have subject. Now I will plot for you a few subjects. Each one has been measured after 2 administration of the drug, or 2 different administration of the drug, or 2 different occasions. So in this case, you see that the 9 patients were measured twice, and they always felt more or less in the same place. All of them in the middle of the therapeutic window, all of them very reproducible. Can any one of you name a drug that behaves this way in our field? Rivaroxaban, apixaban, dabigatran. You give a fixed dose to everyone. There's no need for PK here. Now, are they so reproducible? No, but the therapeutic window is huge. They are safe and effective from very low to very high. So we don't really care, provided we know that most of the patient will stay in this range and will have a reproducible level, if they are not in all those situations that David mentioned before. So in this case, you don't need PK, you don't need prediction. Now, look at this case here. Same layout, but this time this is the situation. All patients are showing different levels, and the level varies over time within each patient. Can you name a drug in our field that behaves this way? That was possibly right. Warfarin. You can't predict the dose of warfarin. You have to measure over and over and over, because the requirement changes over time. So again, there is no meat for pharmacokinetics here. You can help predicting the starting dose, the loading dose, but that's what you can do. Then you need to measure over time. This is the case for factor concentrates. They are reproducible. So they vary a lot patient to patient, but within each patient they are reproducible. This is the case where you need to do the measurement once, but you can use that measurement to predict future doses and to be sure you get a level in everyone. Now, why you cannot use population estimates? These are some factor 8 available on the market. I'm not sure if they are available on your market, but they are in general. And they are ranked based on their half-life, from 11 hours, novo 8, just not to make names, to 19 hours, eloctate. These data come from publication. I'm not throwing numbers. These are the half-life reported in the pilot or pivotal trials for this molecule. Now, before I try to convince you that if we could use this data, why we would still using all these molecules? Why we would not all be using eloctate? That gives a longer half-life, so provided it is available and is affordable, why don't you use the one with a longer half-life? Wouldn't you benefit the population better? There are two reasons not to do so. One, I want you to tell me, how would you rate the average evidence for PK comparison across concentrate? My previous slide, do you believe it? Do we have this slide? Yes, why don't you vote? And you tell me if you believe or not my slide. I didn't make it up, I just copied data from the literature. But you have low confidence. Good, good boys or girls, whatever you are. So why you don't believe it? What's reduced the comparability of PK studies? Now, you have shown you are good. Now you have to show you are good for a reason. Why you don't believe that slide? Let's see. All of the above, or population characteristics getting thinner and thinner by the minute. Yes, because those studies are small, the population are different, so they may not be comparable, and the studies are done in the fancier way you can imagine. And the analysis method is whatever they wanted to do. Sometimes you see crossover study, well, that's nicer, is the same population, they get both concentrates, and then to analyze one and the other, they use two different methods. Well, that for sure, usually that method doesn't help the comparator unless in one single case that was published where the method was helping the comparator, and I still need to understand why that was the case. I won't cite the study for I don't know. I can tell you which study over coffee. Anyways, good. So you know that we can't believe those differences. But even if we were to believe those differences, the main reason we can't use those data is listed here. Can you tell me which one is? I understand you can't compare for study design, population characteristics, analysis method, as inter-individual variability do anything with our incapacity of using average data? Yes, that's the reason. If you plot over this data, the variability observed in the study, there is no difference. You can get as low as 7 hours, as high as 30 hours in random patient across all the studies with all the concentrates. So, and not necessarily the same patient would get 7 across. He might get 7 here, 10 here, and 15 there. So you really need to measure. And what you need is the profile. You need to draw the 3 samples, get an interactive profile where you run your mouse and it tells you which concentration at each time after the infusion, or some confidence interval, credibility actually interval, predictive intervals around the concentration that patient will have at a given time. And after you have a profile like this, it's very easy in a population PK setting to say, okay, now that I know the PK, what if I give 2,000 units on Monday, Wednesday, Friday? And in a nanosecond you get, okay, this is what you infused, say this was 1,000 units, this was the curve, now you increase the dose, the software scales for you the effect and show you where you reach during the week, and can also tell you what the trough is after the 48 interval, after the 72, what's the weekly dosage, and so on. Wouldn't you find this useful in deciding how to treat a patient? Now, can you do this back of a napkin? You may say, yes, I think I can, but I dare you, I'm sure that if you do, you will get with 3 or 4 like the 2 guys on the screen. And the reason you can't use a back of napkin is that you have cases like this. You don't need a computer. If you have this 4 point to draw that line, I can do it, and you can do it, anyone can do it. But the common situation is this one, where you have these 3 points. This is 4, 24, 48, and you are interested in what happened later and what happened earlier. And you can't really draw those lines unless you gather information from a population of patients who were treated with the same drug over time. And the population PK approach takes into account weight, lean body weight, age, blood group if you provide, von Willebrand factor level if you provide, and any other covariate that we might have available in understanding. There's no standard curve for everyone. There is a likely curve for the old, the young, the heavy, the light, and so on. And the other thing that is not easy to do by hand is, okay, this is what I measured, now I increase the dose. You can't do this back of a napkin because it's not intuitive to modify a bi-exponential curve just by shooting. And if you take the time of going to the WOPS interface and you try to see what happened by increasing the dose on a Friday of 1,000 units, on the Sunday evening, nothing. You can't measure a difference if you give 2,000, 2,000, 3,000, which we sometimes do to try to protect the weekend. 2,000 you have to increase to 6,000 to see a difference in a trough of 72 hours. So there are some details you would like to have a computer calculating for you. What is behind WOPS is exactly this one here. We have spent time gathering PK data from registrational studies from pharma and from investigator. We got about 700 dense data PK. We developed model for almost all the existing concentrate, and we make it available over the web to a network currently of 30 countries, over 130 centers for about 1,500 patients, about 3,000 PK, the possibility of calculating at the bedside PK out of few data points. So this is how PK can be used to tailor treatment until we will be using factor concentrates. Now, inhibitors. I'll close 5 minutes on inhibitors. Yeah. And I have a disclosure here. So you know that in the progress of your career, you start as a first author, then you become a last author, but when it's really important and when you get your name in the title of a paper, right? So, not everyone gets there. I did. And actually, I did to get some fellows in the community up there saying that I didn't understand the heck of methods. So they might have been offended, but what I said about CPET, I don't know. Anyways, I want to make this disclosure because you may stop listening and you may stop believing me. I still think that there is some truth in what I'm going to say, but anyways, I'm not citing specific studies. I did, and you see what happened. You get famous. We'll cite some concepts. So, side effect. Inhibitor is a side effect of treating hemophilia, right? So you would say, which study design is best to study side effect? Observational. It's in every clinical epidemiology textbook. Now, side effects are usually rare and not linked to the mechanism of action. You don't use observational studies for measuring side effect of rivaroxaban and dabigatran. You measure them in trials because they are common and because they are linked to treatment in a very clear and partially known ways. But if we were to study side effect in observational study, we would compare exposed and non-exposed. We usually do that when we cannot randomize people to smoke or not, or to have or not cancer. Would you enroll in a study where they tell you you will be randomized to have or not cancer? No, you don't usually. So you need observational studies, and then you stratify for whatever makes sense to use as a adjustment, because it's a confounder, PACS per year, age, sex in this case. Or if you are interested in, does rheumatoid arthritis increases the risk of myocardial infarction, then of course you will adjust for treatment duration, and so on. And you can't randomize people to have rheumatoid arthritis or to get or not a specific treatment. You can, but it's not that treatment for rheumatoid arthritis is so effective in giving myocardial infarction that a standard size randomized trial can show a difference. So this is what you do. The problem in using an observational design to study inhibitors that we have some genetic non-modifiable factors, and that's okay, you can adjust for those, but we also have non-genetic factors that are all linked to treatment. When you start, how much you give, what's the reason why you treat, which product you use, and so on. And you cannot really adjust for all of these. It's too complicated. Even in a study like CPET, the randomization was to plasma-derived or recombinant. But the way treatment was used was completely left to the treater. And even if on average it seems similar, it's not randomly assigned. Now, there would be treatment design that let us get some more confidence about the rate of inhibitors and the risk associated. And depending if you want or not to do prospective retrospective, if you want or not to accept the risk of bias, you can use different design. For some reason, the hemophilia community is extremely impermeable to science in designing studies. And notwithstanding this is well known and is feasible, even if the trial requires long time to develop the outcome and require large population. We have seen at least twice with Rodin that you could possibly see a difference between different molecules. It's true, it's not, I don't know, but it looks like you can see it if you do it properly. And in CPET, by randomizing less than 300 patients, there is evidence that plasma-derived and recombinant give a different rate of inhibitor in PAPs. The main effect of CPET was that EMA is now dropping the requirement for PAP study. That's great. We had finally a study showing that in PAPs you can see a difference that you cannot see in PTPs, and the result is we stopped doing studies in PAPs. We only believe PTPs that shows that you can see a difference. That to me is clever. Oh, but there are not enough PAPs to enroll for all the molecules that are coming up. Do we need all that molecules, or we'd better wait for something later? Or if we really need them, do we need to use them in PAPs? Can we use them in PTPs, and for PAPs we wait until we know? I see a disconnect between knowledge and action. Now, can we predict the risk of inhibitors? It's really difficult. And the main reason is that most of what makes the risk of inhibitor is the way we give factor. You can't predict the risk of inhibitor after you start treatment and then you say, oh, you should have not used that concentrate. So there are a couple of risk models, but they include how long you treated, for which reason, and how intensively. I need to know before if that makes an effect or not. And even if I was able to predict, and even if it's a difference, what we have seen in clinical studies is that even the lower group ever still has a 20% risk of inhibitor, 18% risk of inhibitor is too high to make sense. We need to move on, stop interpreting what we see, and we need to start thinking of inhibitors in a different way. That's what I hope you'll bring home as future rheumatologists, replacing us here in front as soon as possible in not really in caring for hemophilia. You can trust us about how to care for hemophilia patient. But if you really want to solve the problem of inhibitor, understand why they develop, learn how to prevent them, learn how to eradicate them, leave alone. Yesterday, I didn't want to it's not safe to rebate to Lou, but when he said that ITI still stay as the best way to treat a patient with inhibitors, even if you could give a emicizumab, you have to eradicate the inhibitors. Well, as he said, the only evidence we have for ITI to make any sense is in the rabbit. We have no evidence in the human being. The only randomized study ever done, Charlie A. and Donna Di Michele, randomized patient to receive 200 units daily or 50 units every other day, and showed that the effect as to tolerance is identical. Yes, the one on 200, they bleed less. Oh, we didn't need a trial, that was pretty obvious. They get to tolerance a little earlier. Again, maybe that's a gain if you have to be treated not to bleed. But if you can be on emicizumab and you don't bleed, can't you wait 6 more months to get tolerance? We have shown in a paper that was almost impossible to publish that if you don't do any tolerance, you still get the same rate of success at 6 years. And luckily enough, that was replicated in Brazil. So there are 2 independent papers showing that tolerance might likely do nothing. Nothing is not appropriate. It does good. It does good, at least to pharma. But to patient, it prevents bleed. It doesn't have any effect on tolerance. In rabbit, it does. That slight difference between a rabbit and a human being. And why we insist that way? There are innovative approaches to immune tolerance. It's possible to tolerize by giving factor VIII by mouse. You can engineer cell. We do nothing of that. We just bump factor VIII into patient and we wait for something to happen. So hopefully in the future some of these will become reality as gene therapy. And I decided to stop criticizing studies on inhibitor. I just don't read them and wait for something better. You can't read everything, guys, come on. So I'll stop here.